Okay, so welcome everybody. Thank you for joining us this evening. Tonight we'll be discussing PGT-A testing and could it be the key to your IVF success. So we have Dr. Elias Tsakos here with us. Thank you for joining us from the Embryoclinic in Greece. So I will leave it to you, if that's okay. Just to say first that this is being recorded, but everybody is anonymous on it. So all of your messages and nobody can be viewed on it. So just so that everybody knows. But I will open up the presentation.
All right, thank you very much. Thank you, Carly, for hosting this. I'm very grateful for the invitation to be here. I will try to keep it short and sweet. I know it's anything between 7 p.m. onwards in Europe and perhaps a little bit earlier in the rest of the world. So I will try to keep it as concise as possible. PGT-A, this is originally a subject for embryologists, but since I'm usually included in the clinical questions and the clinical decisions, I will take the responsibility of presenting my point of view about this technological innovation, which may indeed be the key to success for many patients, but also definitely a key to providing our patients with options. So I have no conflicts of interest regarding this presentation. So I will very quickly go into the introduction, that is the fact that after the age of 35, the fertility declines dramatically. We can see the graphs here portrayed by both the Society of Assisted Reproductive Technology in the US, but also from the European societies, where we can see the massive drop in live birth rate per cycle in IVF in women over the age of 35. And this is usually due to the fact that embryos, no matter how beautiful they look on morphological grounds, even if we create good quality blastocysts, after a particular age, the chance of that blastocyst being abnormal genetically is very high. And as you can see here, the significance of aneuploidy, this is the abnormality, the genetic abnormality, is quite high, and it increases with age. So in women over the age of 35, more than half of the beautiful embryos could be genetically abnormal and therefore could be inconsistent with a normal pregnancy and normal birth. And of course, this increases not only after the age of 35, but even after the age of 31, as we can see in this graph. Blue is normal, genetically normal embryos, and anything other than that, red, green, and purple, is abnormal embryos. And you can see the graph dropping after the age of 30 and more dramatically after the age of 35. And this is something that we should be aware of, in particular when we're counseling our patients regarding their options. So in women over the age of 35, more than 1 in 3 embryos are abnormal. And of course, as we hit 40, more than 50% are abnormal. At the age of 44, as you can see here, about 90% of embryos are abnormal. So we're talking about seriously affected genetically, seriously genetically affected embryos. Now, what is PGT-A? PGT-A is a fine form of embryonic surgery, if you like. And we're highly skilled embryologists, and we're very fortunate to have been working with, I've been very fortunate to have been working with very skilled and amazing people over the last 35 years. And of course, here at Embryo So what they can do is they can take one piece of this beautiful blastocyst. I'm not going to go into the technical details, but they can take a small biopsy of an embryo, a biopsy that doesn't affect the quality of the embryo, doesn't damage the embryo, and then we send this for examination for testing. And of course, there's a lot of options, how we do it and how we test it. And of course, we are expecting some of those embryos to be abnormal. I mean, even younger women may have a rate of abnormal embryos because of genetic dysfunctions here, the genetic anomalies. And of course, unless we treat those, unless we test those embryos, the risk of abnormal outcomes of IVF is pretty high. So this is what PGT-A is. Now, what is the evidence? I mean, you will hear, this talk is not really prepared for scientific conference. However, I think most of you are very well informed, and I'm very happy to testify here that the majority of my patients are very well informed, which makes our job very easy, apart from being very productive and very pleasant. So the guidelines, they do not exactly recommend PGT-A testing. And this applies to all the European Society, the British Society, the Royal College of Gynecologists, to which I'm very honored to be a fellow of, and of course the American Society. So most of those societies, they do not exactly endorse PGT-A as an effective way in increasing success rates. But why is that? And why is that in the light of the fact that we know that the benefits of PGT-A are listed here? And one of the benefits is that, of course, it increases the chance of success per embryo transfer if we have a genetically normal embryo. It decreases the miscarriage rate. I mean, the chance of avoiding a miscarriage is higher. If we utilize only normal euploid embryos, as we call them, genetically normal embryos, we know that the time to pregnancy is shorter. And together with that, the risk of anomalies is less. And the risk of delivering a child with anomaly is less. And of course, by using genetically normal embryos, we increase the chance of a single pregnancy, which is the golden rule in successful outcomes of IVF. So why is this happening? I will try to explain why. This is because most of those societies, and even the Cochrane Library, which is one of the most robust scientific tools, if you like, that we use in order to evaluate our add-ons, they use the live birth rate as a predictor and metric of PGT-A effectiveness, which is, of course, not the case. So they're using the wrong metrics in order to evaluate the value. And here, this is the essence of my talk. I have to stress that PGT-A is only a diagnostic test. Of course, PGT-A does not improve the overall cumulative pregnancy rate per cycle because it's only a diagnostic test. It does not create viable embryos. So if a couple have 5 embryos, and if we test those and 2 are normal, yeah, of course, the overall chance of success is probably going to be the same because these are the normal embryos. However, the quality is going to be much different. And by ruling out 3 abnormal embryos, we don't have unnecessary embryo transfers with abnormal embryos, which not only do they carry the risk of not implanting, but they also carry the risk of miscarrying. They also carry the risk of producing an ectopic pregnancy. And most importantly, they carry the risk of having an ongoing pregnancy with an genetically abnormal embryo, and with all the various implications. So this is what PGT-A does. It increases the pregnancy rate per cycle because we have a genetically normal embryo. And of course, not all genetically normal embryos implant, but many of them do. I would say most of them do. There's less chance of miscarriage, there's less chance of anomaly, and so forth, what I've already mentioned. So my suggestion, my scientific opinion is that perhaps we should be considering PGT-A testing, not for everyone, but for the ones where the value and the benefit seriously outweighs the potential risks and costs and complications and everything. And this is definitely women over the age of 35, in my opinion. I'm not going to touch at all the case of men, although I have to whisper here a little bit that I believe that just like we include women over the age of 35, we should probably be including men over the age of perhaps 45, and if not 45, 50, because we know only too well that the chance of male source embryo genetic anomaly may be associated with the advanced male age as well. And my prediction is that in the next few years, and this is the duty of us, of the reproduction specialists, is to include in the indications for PGT-A testing the male age as well, not just the female age. Here we can see some very good papers, very good pieces of research. So, you know, one of the arguments of the opponents of PGT-A is this question: and why, you know, instead of checking if they're normal or not, why don't we just transfer 2 embryos or more, even in some countries where it's legal? It's not legal in Greece, by the way, to transfer more than 2 embryos in women under the age of 40. Because it doesn't make sense, because, and this is an amazing piece of work, which showed that this is not justified. And by transferring more embryos, all we do is we reduce the quality of our IVF, and really we shouldn't be doing this. And here there's a possibility, this is another technical opportunity, that PGT-A can be performed in the first cycle. So this is particularly valuable for women and couples traveling overseas from long distance. Instead of freezing the embryos and testing them, there's always the possibility of doing that test on a first cycle. Okay, so what are the concerns? The concerns are whether there is an effect of the biopsy on the quality of the embryo, and this is a wonderful study published recently that this is not the case. And what about mosaicism? This is the case in which the result of the biopsy shows a little bit of an abnormality, which may not be serious enough to discard the embryo, but also it's a little bit worrying about the outcome. And again, we know that now we can assess the level of that mild anomaly in order to make an informed decision. And this has been confirmed with studies. And the status quo in Greece is that, and of course, one of the problems with PGT-A is that, you know, in my opinion, we shouldn't be using this technology to everyone. For example, there's no point using PGT-A in egg donation cycles where our donors are younger than the age of 30. It's not justified, perhaps, there, because the chance of genetic anomalies is so low that it doesn't justify the risk, the cost, the potential dilemmas associated with PGT-A. So in Greece now, and actually recently, the law has been changed, and it allows PGT-A testing for women over the age of 38. Now, this has taken a lot of years of discussions, if you like, and dialogue between the reproductive specialists and the government, and we have been faced with a lot of bureaucracy. As you can see, we've been stuck by bureaucracy, and now it seems to be liberating us a little bit. So what are the future perspectives? Definitely the improvement of the technology of PGT-A testing. And this is a technology that's been around for well over 15 years, perhaps 20 years. It certainly has evolved over the years, certainly now safer, more effective, quicker, and more accurate. But of course, there's always more research now on non-invasive PGT-A testing. In other words, PGT-A testing that doesn't necessarily require the biopsy of the embryo. We're looking into the assessment of the various levels of mosaicism, of low-level genetic anomaly, if you like, and of course, PGT-A testing with NGS. This is also in the horizon. My team and I were very proud to have been involved in a multi-center study, which was published a couple of years ago and presented at the European Society of Human Reproduction, where we looked into the non-invasive PGT-A testing from the blastocell fluid without biopsying the embryo itself, and the summary results are quite promising. So perhaps in the future, our group, together with other groups in the world, can come up to some conclusions that perhaps a full biopsy is not necessary, and maybe we can obtain good results from non-invasive testing of the blastocell. Now, this is a little bit of a paradigm of the tendency in medicine, and of course, this combines my two greatest loves, scientific loves. One is surgical gynecology, and the other is, of course, fertility. So just like in gynecology, from laparotomy for big incisions, we went into minimal invasive surgery. Just like in obstetrics, in pregnancies, we don't do that many amniocentesis anymore. We don't stick needles in women's bellies in order to diagnose genetic anomalies, and we can do this through blood testing, non-invasive prenatal testing. So similarly, just like the ancient Plutarch and the Romans, the parallel lives, PGT-A testing, perhaps with the use of AI, with an application of artificial intelligence in the future, could be replaced by non-invasive genetic testing, which would give us all the benefits of an invasive test with bigger safety and, of course, equal success. So this is just a little wish and hope for the future for those ones, because I can see some wonderful people, some amazing scientists listening in. You can take a screenshot of the literature. I'm very happy to share that. And this is where most of all of my data came from. And finally, I would like to thank each one of you for attending. And of course, my team, who not only have helped me prepare this presentation, but also they've been backing me off in order to prepare my presentation tonight. Thank you very much. And I'm ready to take questions.
Thank you. That was fascinating for me. Thank you very much. And
Thank you.
Very interested in the testing men over the age of 55. I think that is going to be huge, and the non-invasive testing as well. So it's all very, very exciting to see what's to come. So thank you. So we've got some questions. Please feel free to put questions in the chat, and I will work my way through them. So we've had a few that came before we started. The first one pretty much answered in the presentation. The second one being, what are the risks associated with PGT-A, and what is the rate of a false positive, and I can never say this, aneuploidy, and when is it better to opt for an amnio instead of a PGT-A?
Sure.
There's a lot there.
Of course. I mean, the risks are, I think we have to balance. It's not for everyone. That's my personal opinion. Unfortunately, it has been commercialized a lot, PGT-A, for various reasons. On one hand, we have the patients believing that this is the holy grail of IVF diagnosis, which is not. Mm-hmm. There's other pieces of the puzzle, which are equally, if not more important. And of course, there's the commercial demand. I mean, I think from this stage, I can tell you my view on this. Unfortunately, IVF clinics, they're commercial units as well, and sometimes driven by forces other than pure science and all that. So I think we have to balance all that, and I think we have to not sit on the fence, but also just remember that nothing is perfect. There's no perfect world. There's no perfect test. Even if our patients are prepared to go the extra mile and spend extra thousands, I think as scientists we have to hold off providing blanket approach. So in my clear opinion, it's not for everyone. The value of PGT-A is mainly for couples where the woman is over the age of 35, and of course in couples where there's obvious chromosomal anomaly. And I would also add perhaps patients in cases where there's been history of recurrent implantation failure or miscarriages. So definitely not for donors. I mean, there is a question on the panel, if it's 25% in younger women, why don't we do it on the donors? Because this is considered a very low chance. That's why. And because PGT-A is not entirely free of risks. So there is a risk of damaging the embryo, of course, through all the manipulation.
Mm-hmm.
There's all the risk of storage, although we know that now that freezing and storage probably has equal, if not better chances than the first embryo transfer cycle. It's all the added costs to the patients. I mean, for me, to my mind, extra cost means less chances in the future because all our couples have certain budgets. So, how many attempts can they have for the same budget? So I think we need to be very careful when costing treatments and add-ons which do not offer clear advantages. That's my opinion. Now, if we feel that in any case, I mean, the PGT-A is a screening test. I mean, it is diagnostic really, but it's also screening because the accuracy is not 100%. So depending on the labs, you will read in the small print and the disclaimer that they all say that they recommend an amniocentesis in order to confirm the finding. So again, we have to be in a dialogue with the obstetrician, with the team that is looking after the antenatal care of our patients, and very often I'm actually called into a multidisciplinary team in order to decide. And again, there my opinion is always very clear. Do all the non-invasive tests first. I'm a very non-invasive person, although I was trained with heart surgery in the 90s with big laparotomies and very heroic pieces of surgery. I mean, I was brought up in the case where in the era where we used to do laparoscopic egg collections,
okay.
under general anesthesia, and our patients used to stay in hospital for 1 or 2 days after their collection, and now they stay for less than an hour. So, I've been around enough time to be a huge fan of minimal invasive approaches. So in terms of how we double check in pregnancy, scanning is very valuable and non-invasive. Non-invasive prenatal testing like PAP-A testing, beta-HCG testing, non-invasive prenatal testing by means of fetal free cell measurement in the woman's blood. And then, yes, of course, if there's still doubt, amniocentesis may be an option.
Okay, thank you. And I don't know about in Greece, but over here in the UK, the cost is quite vast. The difference in the cost from the different clinics at the moment seems some clinics charge per embryo, others charge for kind of a batch of embryos. So it can be really very, very costly to add it in. Absolutely.
I mean, roughly, no matter whether it's the UK, Europe, or the US, roughly the cost of PGT-A can be as high as the cost of IVF itself,
mm-hmm.
drugs. So I always keep that math into my head. What is best for the benefit of my patient? If I offer them for the same amount 2 cycles of IVF, or if I offer PGT-A in 1 cycle.
Yeah.
And I think this is a very important discriminatory factor in order to understand what's best for our individual patient.
Yeah, yeah. We have got one that I'm going to leave to the end if we've got time. So we've Helen's post here from the egg donor. You've already answered that. So how do we check that a clinic's embryologists are experienced and have the proper laser to do the biopsy needed, and that they will not damage or destroy the embryo, which I think is always a huge worry, isn't it?
Yeah, sure. Well, how long is a piece of string? I mean, this is from my experience. I mean, I've been, as I said, I've been around 35 years. I've worked in more than 10, maybe 12 clinics, and I have visited more than 100. All of them that I've visited and I've worked at, the most senior embryologist is performing the embryo biopsy.
Yeah.
And now, of course, as it becomes more and more common, I mean, for example, in the past, when I came to Greece from the UK, there was only perhaps 3 or 4 people in Greece performing embryo biopsy. Now, there's quite a few people around. So this is a skill that has been developed over the years. And, patients, the same way they trust us to do everything else, from a neck flexion to an embryo transfer to a hysteroscopy to laparoscopy, the same way they trust our embryologists to do ICSI, I think they should trust the clinics. But my impression, and I'm very confident on that, is that I haven't seen a single IVF unit where there was no experienced person performing PGT-A testing, and usually is the most experienced embryologist in the lab.
Wonderful. That's good to hear. That's good to hear. And another question from Helen. What about testing frozen embryos?
Sure.
What do you think about defrosting?
It can be done. I mean, technically, it can be done. The question is it worth considering? Is it worth doing? It can be done. We can always test and refreeze, or we can do rapid testing, as we call it, and culture for one more day. But I think it requires very careful counseling. And for me, PGT-A, the most important deciding factor about PGT-A is it valuable for the individual couple, the individual patient. And I would like to give you some examples of what I consider valuable and what not. For me, it's equally valuable for a 37, 38-year-old. Well, if a 35-year-old has never done IVF before, and if they have no serious issues, and if we have blood, also please remember that many units, they don't deal with blastocysts, they deal with day 3 embryos. Yeah? They don't always deal with blastocysts. It's easier, cheaper, and less risky to handle day 2, day 3 embryos. So I think it depends. For example, for a 35-year-old doing their first IVF, I would definitely not suggest PGT. For 36, 37, same, doing their first or even second IVF cycle. As a clinician, I always like to analyze every cycle step by step. And I like to optimize things according to my experience and my clinical judgment. I would only suggest PGT-A, for example, on someone under 38, if they've had more than 2, perhaps unsuccessful, or 3 transfers.
Okay.
And in that case, I would probably consider that easier. PGT-A, I would move on to PGT-A, for example, if everything else felt perfect. For example, if somebody had 2 unsuccessful transfers and everybody commented on a difficult embryo transfer, I would probably try to correct the difficult embryo transfer, which can be corrected very easily with hysteroscopy and dilatation, before jumping onto PGT-A. I would, personally, I like innovation. I'm probably well known for copying, the pioneers in the world, and jumping into being amongst the first ones to to copy their innovations, but I'm also very skeptical to see what's best for my patients. And PGT-A is a very advanced, complex procedure, and I would definitely resort to that if I have excluded other factors. So a recurrent implant, for under 37, 38-year-olds, a recurrent implantation failure would be an indication, or miscarriages. If they've had, one miscarriage and a couple of failed implantations, yes, then yeah, and everything else was optimal, I would consider PGT. Now, for over 38, 39-year-olds, where the chance of genetic anomaly is very near 40, 50%, I probably would consider that. I'll definitely discuss with the patients. Depends on the logistics as well. Depends on where they live. Depends on whether they have the ability to go home and come back. Depends on a lot of factors. And also PGT-A has, in my opinion, very important place in couples where the woman is over the age of 40, where they've had multiple failures. They keep trying. Of course, they don't give up on their eggs, which I'm very supportive of. But over the age of 40, I like to know for sure, I like to be certain that what I'm transferring is genetically normal.
Okay.
And I can give you a very nice piece of research, which was published this year, that up to the age of 42, 43, one genetically normal embryo at 42, for example, has the chance of implantation of a 35-year-old.
Really? Okay. That's wonderful.
Yeah. And this, of course, explains the amazing miracle babies we have on 42, 43, 44-year-olds. Yes, some of them have genetically normal embryos, and their chance of implantation is so high. So I like to know, over the age of 40, I generally like to know that at least I'm transferring a genetically normal embryo.
Yeah. Okay, thank you. Right, I might put this question up actually, so that from Jane, so then you can see it.
Right, okay, can I read it? Okay, 40 live births, AMH, blood work, adenomyosis, 7 miscarriages, maybe due to genetic anomalies. Yeah, okay. IVF, PGT-A, do you have any advice? Adenomyosis, how many retrievals would you expect I might need? I want from a child. Okay, first of all, Jane, congratulations. You're a courageous woman, and congratulations. I'm speechless. Yeah, I think there's more than one factors there. And of course, this is touching upon my other big passion, which is endometriosis and adenomyosis. Adenomyosis, I'm sure, is a cousin of endometriosis. So the chance of having endometriosis as well as adenomyosis is pretty high. I think you've reached the stage now over the age of 40 where everything needs to be optimized. I definitely believe that PGT-A is indicated in your case because of your age. So I would you have two indications for PGT-A. One is your age and the other is your miscarriages. So I would definitely go for that. And adenomyosis, I would optimize as much as I can. My suggestion, I can give you a short list of what I would do. One is a highly specialized 3D, 4D ultrasound scan by someone experienced in endometriosis scanning. 2, maybe an MRI scan by someone experienced in radiology assessment of endometriosis on MRI. There aren't that many people around, but if you look hard, you will find that person. Most likely hysteroscopy in order to assess the quality of your endometrium. After so many miscarriages, unfortunately, the chance of abnormal endometrium is pretty high. So I would like to evaluate that by means of visualizing with the hysteroscopy, but also doing some testing on the tissue, definitely for endometritis, most likely for microbioma, for microbiota, and maybe for NK cells. But I would definitely like to assess that. I wouldn't completely exclude the laparoscopy in your case for superficial endometriosis, which may not be visible on the scan, or on the MRI scan. And I would like to introduce a new technique which has been launched recently in the last few months. It's called EndoSure. It's an amazing, miraculous technique which most of you might not have heard of before, but I've had the privilege to be discussing with the inventor of this technique. There are some belts, just like the ones you put on for your CTG when you're pregnant, and it can assess if you have endometriosis without invasive tests. So
Wow.
I would look into both angles. Definitely, I would like to ensure a genetically normal embryos, because I think there's two elements there. This, for a fertile couple, for a fertile woman like you, in order to have this adverse miscarriage history, it's not just the one enemy. I believe there's two enemies. One is the quality of the embryo, and the other is the adenomyosis.
Thank you for that answer. Did you say it was called an EndoSure? EndoSure.
Yes.
Oh, I'm going to be straight on Google after this and look it up.
Absolutely. As far as I know, this is an amazing invention. I mean, I've been very fortunate to be following this since it started about 1.5 years ago. And there is one provider in the UK. I don't know if I can mention that. That's Professor Amso in Cardiff, who is one of my teachers. And I've had a conversation with him a few weeks ago, and this is very reassuring because it's totally non-invasive and it has a diagnostic accuracy. I mean, the papers say 100%, the research papers,
Wow.
presentations, but even if it's 90, it's very good enough for me.
Yeah, that's incredible.
Look out for that.
Yes, I will be. Thank you. Okay, next question is, what's the difference between PGT-A and the 12-week genetic tests that pregnant women have?
Yeah.
In many countries, they don't do PGT-A testing.
Sure.
What can they do to not go through as many disappointing? So I guess that's kind of losses, isn't it?
Yeah, absolutely. Thank you so much. That's a very relevant question. I mean, PGT-A is pure prevention. We don't let it happen. Pure prevention, PGT-A, which means that we test the embryo before we implant it. So if it's good, we implant it, good, genetically good. If it's not good, we don't. So that's proper prevention. The 12-week scan is early diagnosis, early detection, is not prevention. Okay, so there's a huge difference.
Mm-hmm.
One is we don't let bad things happen. Two is we diagnose, we discover bad things that have happened early. So huge difference.
Yeah. Thank you. Okay, we've got one here from Dina. If there are a few embryos from eggs that are 38 and they're frozen eggs, but the person is now 48, would you recommend PGT-A testing or not take the risk? So I guess she froze her eggs 10 years ago.
Sure. Okay. First of all, Dina, congratulations. You were proactive there. So your eggs and your embryos that will be produced by those eggs, they have the potential, they have the health of a 38-year-old, not of a 48-year-old. So that's a good thing. If you don't have history, if you didn't have history of miscarriages or any adverse factors, I probably wouldn't PGT-A test them, I have to admit. What I would do, however, is that I would be very very careful in screening you, and in particular your uterus, the endometrium, your blood tests, your hormones. You as a whole person before you have the implantation. So I think you've done a good job there, having frozen your eggs at 38. But now at 48, what matters a lot is your uterus, your environment, your blood levels, your general well-being, your situation, etc. So that's what I would do.
and the sperm that you're mixing them with, in
Yes.
my view.
Of course.
They're precious. They're precious. They're precious.
Thank you. So they had the 50% stakeholders, Carly.
Yeah, absolutely. Absolutely. Right. So we've got another back hit from Jane. So Jane said, I had a laparoscopy. She had endo removed in October. Okay.
Good.
And then,
Yeah.
And then a question from Helen. During a biopsy of the uterus, do you test calendar day 56 to calendar day 138?
Yes, absolutely. Absolutely. And then we quantify those, and we reach a conclusion whether it qualifies for endometritis or not. But also I check, especially for women, we have what we call the RIF protocol, recurrent implantation failure. So when it comes to endometrial testing, as a routine, I always check for CD56 and CD138, but also for microbiota testing, which in my opinion is very valuable and very, very treatable. These are situations which are very treatable. NK cells is a little bit, I'm sitting on the fence a little bit, I have to admit. If there's heavy history, I would probably do it. If there's no heavy history, I'm sitting on the fence. So I don't know about NK cells.
Okay. Thank you.
I think we don't know enough. I mean, NK cells we can test, but we can reach this conclusion. We can have a figure, but there's no solid science behind how to interpret the results. So that's where the difficulty lies, and how those results relate to the outcome. So this is the difficulty. Whereas with CD138, things are very straightforward, and with microbiota testing, they're quite straightforward, and they're very treatable.
Okay, great. Thank you. Thank you. So if anybody has any other questions, then please pop them in the chat. I've got a couple of questions, if it's okay for me to ask, please.
Sure.
Do you see any difference from biopsying on a day 5 or 6?
Oh, the embryos, you mean?
Yes, on the embryo, sorry.
Well, it depends. I mean, generally we prefer day 5 blastocysts.
Mm-hmm.
But it's not uncommon to have a normal day 6 blastocyst. And again, we're playing with hours sometimes. Today I had a wonderful colleague. I was very stressed today because I'd done IVF on the wife of an IVF specialist.
Oh, wow. Pressure.
Yeah. And, I was brave enough to have him in the operating room, and the transfer. He took part in all the care. Amazing guy. I must admit, it was a wonderful, a little bit stressful experience, but wonderful. The guy insisted on the hours. I mean, we even checked the hours of how many hours of progesterone, not how many days of progesterone. So when we say day 5, it could be, it could be day 5.5. It could be day 5 minus. So there's no huge difference between day 5 and day 6.
Yeah. Okay.
In my mind, generally day 5 we prefer. Generally, it means a better quality blastocyst, especially in the last few years where we've been using time lapse, and we know that the morphokinetics is a little bit more regular and more normal when it comes to day 5. Having said that, there's an early day 6 and a late day 5, so there's no huge difference in my opinion.
Okay, thank you. Thank you. We've just got a question here from Helen. What did you say about embryos day 3 to 4? Is it easiest to do testing instead of the 5th day?
Sure. Thank you very much. I mean, embryos day 3, no, I didn't say that. I'm sorry. I probably didn't express it rightly. What I said is that, when I am to evaluate a cycle, when I'm coming to evaluate a cycle, say a failure at 35, the age of 35, and then, I'm wondering whether should I be offering PGT-A to them after one failure. I look into what day embryos did they use, for example. What I'm saying here is that many units are not using day 5 embryos, and they're using day 3 embryos, which may be okay. I mean, I'm okay with that. But if we are to, if you like, when it gets a little bit difficult, the case, after perhaps one failure or two failures, then probably we need to insist on culture to day 5. And by culturing to day 5 and by ensuring that we have a day 5 embryo by itself is a better prognostic than a day 3 embryo. That's what I'm saying. So, so put it this way, the value of a day 5 embryo, the implantation value, equals 2 day 3 embryos.
Yeah, okay.
And the value of a tested embryo, of a PGT-A tested embryo, is again the same as 2 untested embryos.
Okay.
So one tested embryo at blastocyst stage probably has a value of 3 or 4 embryos of day 3.
Yeah, yeah. So huge difference. Huge
and
difference.
By doing this, we minimize the chance of twins. I mean, in the old years, I have personally transferred 3 and 4 embryos in my early times in the 90s in England. And why was that? Because there were day 2 embryos. Mm. At the time, we were even transferring day 1 embryos sometimes. Wow. Day 5 embryos were very uncommon because we didn't have the confidence to our technology, to our incubators. And the usual story we were saying to a patient was that, oh, well, the uterus incubator is better than our incubators. That was true for the 90s, for the 2000s. I'm not sure it's true now anymore. I think our incubators are equally good. Having said that, as I said, I have no problem with day 2, day 3 embryos for the initial stages of someone's journey. But when the journey is getting a little bit rough, when they've had 2 or 3 implantation failures, in my opinion, I think we have to insist on day 5 and perhaps on PGT-A testing. Yeah,
yeah. The wonders of medical science. It's incredible, isn't it? Absolutely incredible. So if you've got 2 embryos, if you have to transfer 2 embryos at the same time, day 5 and day 6, would you transfer on day 5 or day 6?
Sure. Okay. This is this has puzzled me for decades, Helen, and I have the answer now. It's the stage that they reached that's important, not how many days it took them to get to that stage. So basically, we culture embryos for 6 days if they haven't become blastocysts on day 5. Okay, so by the time they became blastocysts on day 6, they're day 5 embryos. So I would transfer them on a day 5 endometrium, not on a day 6 endometrium, if you ask me. Yeah. Perhaps a little bit later on day 5, but on day 5. So on day 5.5.
Brilliant. Thank you. That's all absolutely fascinating. So I hope everybody got their questions answered. If there's anything else that you want to ask, then please pop them in. And you got a nice thank you there from Helen. But thank you, Doctor. It was I found it absolutely fascinating. So thank you for your time this evening, and thank you everybody for your questions. Oh, hang on, we've got somebody else typing, so let's just see what they're going to pop in. Will we have access to the recording? Yes. So the recording just goes on to, I don't know if you get sent the recording, I'm not sure, I'm afraid, but I know that they're all on the website. So you'll be able to access it as soon as it goes up.
Sure. Thank you very much, Carly. That was amazing. Thank you, everyone.
Thank you. And good night. Enjoy your evening, everybody.
You too. Thank you very much.
Bye-bye.
Bye.